So I want to briefly ask, are there other promising emerging therapies that we should touch on before moving on?
Well, I think there are a number. I mean, ibrutinib has, John mentioned, venetoclax, the BCL2 inhibitor, ABT-199. Some of the early data with that are perhaps a little disappointing because this is thinking of the mechanism of that, this is the disease that it should have been the most active in, actually. But I think we're not seeing it nearly as active as we do in CLL. And then the PD-1 inhibitors, Dr. Nilapu at MD Anderson published a study with the drug pitolizumab, which is probably the first of at the time, we thought it was a PD-1 inhibitor. We did a study in large cell lymphoma, and he did a study in follicular lymphoma with some interesting responses, although we combined it with Rituxan. Turns out that drug probably doesn't work, although we don't know how it works. It probably doesn't work as a classical PD-1 inhibitor. And I think it's been a little disappointing to see some of the others in follicular lymphoma. I mean, we want to think that they're going to be effective, but I'm not sure that we're seeing the same kind of responses, say, that we're seeing in classical Hodgkin's lymphoma, for example, or in primary mediastinal B-cell lymphoma. So I think those are drugs that I think that are going to be looking at. We have a presentation and a poster at this meeting with the SYK inhibitor, TAK-659, that's very interesting in both the diffuse large B-cell lymphoma and in follicular lymphoma. We're seeing very impressive responses with a fairly well-tolerated oral drug. And so these are things I think that we need to be looking at. We need to be investigating different parts of the B-cell pathway, the B-cell receptor pathway in follicular lymphoma. And I think those are going to make, I'm hoping those are going to make inroads in treatment.
It's just, it's enigmatic to me why idelalisib works so well in follicular lymphoma, and it's clearly a proximal B-cell receptor, and the SYK inhibitor, and yet with ibrutinib, the responses are very different in CLL. It appears to take longer from some of the early data, and it's much less. And I mean, I wonder, does anybody have thoughts of why that is? And
yeah, I don't have a good answer. I mean, it is interesting, and I think it's important for the audience, the subtype specificity of, clearly we've known CLL is different than mantle cell and follicular, but it's even getting more nuanced from the standpoint of the other indolent lymphomas. We have data with ibrutinib in marginal zone lymphoma, data presented at this meeting where roughly half of patients responded, which I think is important data, but it's different than the follicular lymphoma data. Again, different patients, et cetera, where the response rates weren't quite so high. So I think it's important to really not lump all these diseases together and try to parse out which you're dealing with the patient and what they're going to benefit from.
For somebody that's practicing, though, but so you go down the pike, and I'm just because I treat mostly CLL for Leo and John. Where do you cut the line? Because clearly some of the patients with ibrutinib had a durable response, but the response was, I think, 21%. What's going to be presented is 21%. Yeah. So where do you sort of say it's not worth doing this versus it's worth, because versus it's worth doing it?
I think it depends what your other options are, and I think if a patient hadn't had idelalisib first and was a candidate, I'd probably try that first. That's not curing everyone, but there are people doing well, clearly. But I think it's certainly something I would pull out in some patients to use, just like other settings.
Yeah, one question in terms of mechanism, when you think about long responses, maybe John or Krishna can answer this, the effect of ibrutinib on T-cell function. And maybe are we seeing some inhibition of Tregs? Is that why we're seeing responses? Or is it a direct effect?
It's a very good question. Actually, I think that we don't have as much data as we need. We're actually starting to look at that now. We've actually utilized these drugs, like drugs that you wouldn't expect to work in the context of graft versus host disease. We have data that suggests that MEK inhibitors, for example, can inhibit T-cell responses nobody would have guessed, and there are now trials of both JAK inhibitors and SYK inhibitors, and I think that, and of course, ibrutinib has been tested in the graft versus host disease setting with effects in chronic graft-versus-host disease where B cells play a role. So I think that, but that is something, I think, just like as you noted with adalimumab, we have to keep an eye out for these, you know, we think of them as off-target effects, but they're really on-target effects where they're affecting things like, you know, ITK, BTK that also have a role in T cells.
I think